So I farm so hard the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so
What's
hard,
good,
let's
fam? The
get
host,
paid.
Jim Pruitt, aka Pharm in the ED, and I'm bringing another episode of the Pharm So Hard podcast. Today, we have probably the most impressive lineup of individuals I've ever had on a podcast. When it comes to ED weight, they're definitely pushing it. So, again, I'm super excited to have this crew on and really important topic today. Again, talking about boarding in emergency department. We're going to be talking with the lead authors of this paper, and what we're going to be doing is really going into why they wrote it, things to look out for, things we should be doing, things that we probably shouldn't be doing. And I'm just super excited for all this. And I want to make a quick disclaimer here. These are the views of the authors themselves, not of their institutions. We're going to be just talking from the heart here, guys. So without further delay, I'm going to go ahead and let our guests introduce themselves. First, we're going to start with a familiar name. Go ahead, Brian Gilbert.
What's up, JP? Thanks for having us. Appreciate you having us on the pod again, and happy to be here. I'm an emergency medicine clinical pharmacy specialist here in the Midwest. Was happy enough to lead this paper as the chair of the ACCP EMPRN. And next, on my screen here, I see Heather, so I'll let her introduce herself.
Yeah, again, thanks for having us. Heather Blue, I am a clinical pharmacist, associate professor at the College of Pharmacy at the University of Minnesota, and work for Aspirus Health in Duluth, Minnesota. I see Dave next.
All right, sup all. Dave Zimmerman, professor of pharmacy at Duquesne University School of Pharmacy and EM pharmacist in Pittsburgh, Pennsylvania. Excited to be on the podcast. Thanks for having me. And over to Alyssa.
All right. Thank you so much for hosting us today. So happy to be joining and speaking on this topic. My name is Alyssa Robertson. I'm a clinical pharmacist specialist in emergency medicine. This was an idea generated a few years back, and so happy to work with this group and be able to represent EM pharmacy practice and kind of give a little oomph behind a topic that we're all near and dear to.
So I know this has been a huge thing, but I want to really start this thing off. And we're talking about ED boarding, specifically the pharmacy side of boarding. When admitted patients remain in ER for hours or days, really, who owns those medications? And what happens when emergency medicine pharmacist becomes the default answer for everything? That's the big thing we're going to be talking about. But I want to kind of just, before we dive into the policy side of things, I want the first question to everyone, and I want you guys to kind of all give your thoughts. What is going to be the first thing that comes to mind when you hear a boarding patient in the ED?
Yeah, so painful, quote unquote, annoying. I mean, it's not fun for anybody involved, whether or not it's the nursing staff that is now dealing with patients and inpatient orders that they normally don't. Pharmacists, the EM pharmacists that are now having to potentially deal with this and manage patients that they normally would not be managing in terms of like non-emergent resuscitations and whatnot. I also think it's like, poor patient quality. I mean, there's plenty of data to support that these patients don't do as well. It's terrible for throughput. It's terrible for, in their engagement and their survey scores. So it's just overall an issue and something that nobody's been able to tackle or grapple. So uh, at least from the pharmacy perspective, there had not been quite a bit, really out there. So um, part of the reason for the genesis of this project.
Yeah, I
And I
feel
think
like the word ugh comes to mind of just like that overwhelming for everyone, as Brian points out. And I think in addition to the things he mentioned, it's just not a good patient experience. They're not getting the quality care. They don't have a nice inpatient bed or room or window usually. Everything from their meals to their medications are just not the standard flow. And so I think it's just kind of that burden on them as well as the whole healthcare team.
I think too, we're used to that chaos of emergency medicine. We all thrive in that. We expect it, and we know how to work through that chaos. But really, that deviation you get in your day to day that you expect to see. So you get that question about aborting patient discharge plans, med rec that maybe you're not seeing in your general practice. And now all of a sudden you're expected to double as the internal medicine, transitions of care pharmacist. So really deviation from what we know is our expertise and what we contribute to patient care.
Yeah, for me, it just means I gotta dust off the old, like, inpatient algorithms and stuff I haven't looked at in a long time, or how do you deal with a patient's own med? I have no idea, like, you know what I mean? So, going back to that stuff we had in orientation.
And I think it's just unique because we get all of this, and I think a lot of times people are now getting FTEs in the ED, but to have them look at this from like the inpatient side, and it's just something that I think is very unique. And it's really a lot of our training, all the focus that we do. I think a lot of it, again, was not made for that. So I'm really thankful. And it kind of transitions us very nicely into this. And Brian, I want to kind of take a first stab at it. Again, what specific problem made this paper necessary now?
Yeah, I mean, if you look at the statistics we quote in the paper, I mean, boarding is surging at this point. While it's not a new issue, this has been like if you go back 20 years, there's people still writing about boarding, but over the past, decade, it's probably been as bad as it's probably ever been in terms of the boarding process. And like any good EM story. This all started in a bar where we were all at a ACCP meeting in Phoenix and just were kind of spitballing ideas and ways that we could promote advocacy for EM pharmacists and a way or issues that are generalizable and how we could go about doing what we could. And at that point, we can speak to administrators and we can speak to everybody around the country and we all know it's an issue, but one of the powerful things I think we did was allow for a collective of authors, not just just a singular institution. We brought together a great mix of, academic institutions, community centers, small hospitals, big hospitals, teaching hospitals, non-teaching hospitals. And I think it adds validity in the sense that this is a problem everywhere. And this was something that we wanted to set out as a way to give the average EM pharmacist leverage to take to their administration to try to, begin to work and solve through some of these problems or at least give what we considered a playbook or checklist as a way to, identify things that we think potentially would be beneficial for the EM pharmacist to be involved with and things that maybe could be reworked with the existing FTEs that are available at institutions.
And one of the things I want to kind of capture, and this may be a loaded question here, is what do you think leaders really misunderstand about this issue? Because I think this is a major aspect. I sent this paper as soon as it's out the press. I sent it directly to my director. But what do you think is one of the most? And all you guys can kind of chime in on this.
I'm gonna shout out Heather here because she has what I still think is overall the the overarching quote of the paper to me, which was from Heather, which is the emergency department in emergency medicine is not just a place, it's a practice. Uh, and we actually, not to shout out any reviewers, actually got told to remove that, and absolutely didn't. We put our foot down and said, absolutely not. Like this is a problem. The perspective of that is such an issue, and I go back to Heather's line, and kudos to her for writing that because that's absolutely when she said that in one of our meetings, I absolutely my jaw almost dropped because that plainly puts the issue at hand, when you think about the perception from, a lot EM's a new field within pharmacy, really. I mean, it's, overall, it's probably more in its infancy than other specialties, and so, this is overall something that, the perception is just clouded by those who don't work in it.
I'm amazed I actually managed to make Gilbert speechless. I mean, that's an accomplishment right there. Uh, but that's the way I see this. And I think so many hospitals and decentral pharmacists are staffed by location, and those specialties are based with locations. The thing with the the ED is our patients haven't been sorted yet. And we didn't really get to see this, and I think until boarding, where now all of a sudden, yes, you were in the location of the emergency department, but you had a med surge patient, a med patient, a surge patient, an ICU patient, a neuro patient, and they were all locationally still in your department. But specialty wise, if those patients were to be up on the floors, probably where they belong and where they need to be admitted, they would have, all the specialties and especially the pharmacy specialty areas, watching that. And I think that's what directors and a lot of other decentral staff kind of miss that place of the ER is so much more than a location. And it really is. That's emergency medicine pharmacists as we start to grow in practice. It is that specialty. And so when our our location gets kind of clouded with these other pieces, it does pull us away from some of our core roles in our specialty.
Absolutely. And you mentioned those core roles. And David, I want to kind of bounce to you right here. From a training and specialty standpoint, again, everyone can comment. Again, what gets lost when the EMP's role becomes too broad?
Yeah, I mean, we kind of lose our, specialty and skills in our area, right? Our goal is to provide optimal care to the EM patient. Obviously, numerous patients are going to come in throughout the day. That's what makes us unique. Some may get admitted, some may get sent home. They'll be there for a variety, of issues. And we want to provide that care to everybody. And EM pharmacists, I think we're all in the same boat here. We do like the adrenaline cases, as was mentioned, but we want to get ROSC, right? We want that positive outcome. But when it gets to the point where we're getting pulled to different areas on things that are not really emergency medicine related, then I think it's gotten, too stretched too thin.
Yeah, and that's one component you feel like you're 3 different people into one at times, and I think sometimes they take that to an advantage. Like, "Hey, I got a pharmacist down there, they can do all the operational stuff." I know they can. They can do all of the teaching stuff. They can do all these other components, and it becomes an area where you're getting split, and I think that maybe there's a whole different topic about how this leads to burnout, but again, we don't wanna dive too deep into that. But David, kinda keeping with you, again, if you had to define the core role, because again, many people may not know what an ED pharmacist does, an EM pharmacist does. What is it?
I mean, providing care to that EM patient, right? And that's what it comes down to. And there are going to be a variety of patients from acuity perspective. But a lot of times our time initially goes to our critical care patients coming in with time sensitive interventions, your traumas, your strokes, resuscitations, that type of thing. And EM pharmacists, we're trained to triage our patients, right, and prioritize what we need to do from providing a medication perspective. And one of the things I think it was challenging, but it was also really unique, and I know I learned a lot from this whole process. Is every ED is different, right? Every ED pharmacist role and responsibility is going to be different. Depends on the types of patients you have at your institution, the type of staffing. What I do is going to be different than what Brian, Alyssa, and Heather do, right? But we're all getting overburdened, and that's what really led to the impetus that Brian and Heather mentioned, and we needed to bring attention to it. I think our EM physicians and nursing colleagues have done a great job for this, but pharmacists we haven't, and it's time that we need to step up and bring attention.
Absolutely. I think it's one of those things where you really have to just dive down and say, "Hey, let's look around. Let's see what we do. Let's actually make a big change." But I want to really dive deep into certain areas, Dave, and we kind of keep with you. You guys can kind of comment on this, but I really want to spell this out. Again, what parts of the EMP's role should be protected during heavy boarding?
Absolutely. So as I kind of mentioned, the things where we're bedside resuscitations, trauma, strokes, those most critical patients, right? We need to be there. We need to assist. Pharmacists have shown to have so many positive outcomes and benefits when doing that. Um, what I like to equate it to is with the normal dispo process, right? If the EM team wants to admit the patient, right, they give sign out to another inpatient team, right? Once that care is transferred, why is the EM pharmacist care not transferred at that time too? So I think that's a really good, delineation time where we can hand things off. And if there are pending issues, right, we're waiting for additional info to come back, labs, anything like that. EM pharmacist can hand it off to an inpatient pharmacist, whether it's a medicine level. Um, ICU, anything like that.
The other
Absolutely.
thing I think that gets lost too in terms of the EMP's role when you're being, stretched too thin and moved around is more so with the EM pharmacists as opposed to, like, other pharmacists, we are very key in the diagnostic, a lot of times these patients roll up and we have no idea, essentially what's going on, and there's that sort of funnel approach. And there are so many times and so many interventions that go undocumented and unpublished in the literature of ways that we can affect the total viewpoint of what's going on with the patient just by having another set of eyes. And when you're pulled and having to then evaluate those boarding patients to care for them, you lose that and you lose that skill. And it's difficult to train and teach because it's a lot of times based upon attrition, seeing the same type of patient over and over. But there are subtle things that an EM pharmacist can do when that patient rolls up that certainly can affect the overall totality of the care that's provided. And that's a aspect that we really couldn't touch on because there's not a ton of literature out there on that. But I think that if you asked and polled any EM physician that works with an EM pharmacist, they want them bedside when they first roll in to figure out what's going on. And that is absolutely lost. But again, something that we really couldn't comment on because there's not a ton of data out there on that.
I'm pretty sure everyone on this call and listening, there's been plenty of times where you're sitting there and you say, "Hey, do we need an ultrasound in the room?" Hey, all of these other components where it's like, "Oh, yeah." I remember a few days ago, I was like, "Hey, you wanna go ahead and get the Lucas and see about if this patient qualifies for ECMO?" These are things that are not necessary in our quote unquote wheelhouse, but these are things that are gonna be directly impacting the patient, directly impacting our team. And when we debrief, they say, "Man, I'm happy for you to be here." And countless times we have nurses call us and say, "Hey, you don't have to do anything, but just be here." Because we know when you're here, things are better. And I think those are the conversations that sometimes, are not documented. These are the things that we can't really prove. And Brian really touched on that. So I'm really thankful for that. And I think Dave, I think we really chatted again, resuscitation, time-sensitive medications, protocols, education, ED, that's where our time should be. So I don't know if we need to go deeper into that, but I think those are some key things. But Heather, I really want to kind of follow up with this question for you, and everyone can kind of touch on it. When the ED is full of borders, what pulls the way, well, again, what pulls the EMP away from the core role?
So many things in our papers, full of some of those examples, but it's those routine things. It's the daily consults for whether Vanco or warfarin. It's finding morning meds. Brian had talked about how our ER nurses aren't used to having to look at the MAR and go through. They're used to once and one orders. And so to gather up all of a daily medications and, what comes from our ADCs versus comes from central, where do we stock them in the ER? That was a big change too, once we had borders of where do we put these. So it's the hunting down medications. It's a lot of operational pieces. It's still the clinical. Is it time to switch this patient's IV medication to an oral? Uh, Route changes. It's really those routine pieces that are still often clinical, but they aren't time sensitive to the same level that what we're used to in ER, and they're more scheduled. And I think when you try to schedule anything in the ER, that's where this disconnect happens. I would love to make sure that that heparin 10A is drawn at 10 a.m. and I can change the dose by 10:30. Uh, but I might be in a resuscitation. And so trying to fit those two pieces together just doesn't fit into what our standard triaging is. And so we are pulled into some of those. more scheduled or routine tasks, and trying to fit them in and around all of the unscheduled, and maybe more, definitely more important in the acuity level, ER tasks.
Yeah.
The other
We
thing you get too, is you're working with physicians and providers that you don't normally work with in
True.
a boarding situation as well. You know, the luxury of having an inpatient team is that you're rounding with them and able to assess and do a lot of things. So you're now having to potentially page or reach out to people that you don't necessarily know all that well. There may be a little bit of lack of rapport, lack of quote unquote trust, especially if you're not routinely interacting with someone. And so, that those things take time as well and take away from the actual, ER patients that you're trying to
Mhm.
still do all those other aspects that you're doing. And I think that's probably one of the most burdensome things for me is trying to you know, one, work with people I don't normally work with, and then two, it's usually in potential situations and patients that I may not necessarily be the most qualified to be taken care of. And so, some of those interventions that may be uh, done a lot more expedited by the inpatient team now are taking longer. Now you're delaying potential length of stays and things like that. So I think it's a whole different process too when you think about just the relationships that are associated with boarding as well and the EM pharmacist.
Yeah, you guys mentioned even the scheduled tasks. We can barely even schedule a topic discussion. I didn't even to schedule and follow through on those things. But I wanted to kind of transition here at this point. And the paper is really careful because again, it doesn't necessarily say MP should avoid border patients altogether. It really says there are tasks that should quietly become that shouldn't be kind of the default job. And Alyssa, I kind of want to switch over to you. Again, what are the most common, role drift tasks that you see?
Yeah, so I think this relates back to some of the points that Heather and Brian have made, where location becomes that definition and kind of title for the EM pharmacist. We're located in that specific place. And also, there's relationships that we've made with our team members. We are that reliable person who is kind of the jack of all trades, can bring information to the table about a lot of different topics. And so, that drift that happens is when we can continue care past that initial resuscitation phase, beyond that initial diagnostic, throwing out those extra ideas, pertinent past medical history, and kind of where do we go from there. So, once we've help to get that idea of what we're treating, how we're treating, and those next steps, that drift comes along with it. We implement medication therapies, but the follow-up lab work, I think of DKA, especially in our department. We might sit on those patients a little bit longer to see if we can make things look better, prettier, maybe get them to more of an intermediate care place instead of the ICU. And everyone comes to you as the pharmacist to say, how are we doing? Do we need to keep doing more? Should we be changing things up? And you fall into that pharmacist role where you're now doing that longitudinal care. Really, I don't know that's our place. And also logistically, people come to you, well, where should the patient go in the hospital? Again, after resuscitation, after we've kind of stabilized, that's outside of what we should be looking at. We're moving on to that next wave of patients coming into our department. And when you can be sitting on 30, 40, we've seen 50 boarders at a time, it gets to be so much. There's medication histories, even one or two questions for one specific med. That can take a ton of your time. So we have other resources in place. We have other things going on. And my other favorite, sticking with diabetes here, but discharge planning. The patient needs their full gamut of diabetic supplies. I don't know. I don't know what our formulary preferences are. I don't know what their continuity is from the outpatient setting to here, but we're looked to as that resource as the pharmacist and having that medication knowledge. So I think really we get ingrained into helping, being knowledgeable on so many topics that as questions come up, we address it. And then we find ourselves moving away from those emergent top priority things as an EM pharmacist. And it's valuable and helpful to the team. But I think we have other value that we can bring to patient care in the emergency department.
And one of the things I really want to kind of dive into and just keeping with you, Alyssa, again, I think it's a very subtle thing. And I don't think many people realize it, but when does helping and in that quote, helping become the expectation, not just from your team, but from the administration?
Absolutely. We are that standard. We are that person that's always in the presence in the emergency department. And even from a pharmacy department perspective, from leadership, you're there. Why wouldn't you be taking care of those things? And from a hospital throughput perspective, too, like if you can help with that discharge planning and getting things in place, why wouldn't that be your responsibility in that role? So I think having to give those examples of the wins that we have in resuscitation, stabilization, in other ways that we help with throughput and volume control is where we need to emphasize and show what we really bring to that patient care area.
One aspect I think about this, and all you guys can kind of chime in, and I'm always thinking about the totality of the career of the EMP. Are EMPs sometimes punished for being too useful? Because we could do a little bit of everything.
100%. We are performance punishment to a T, I think, because we don't say no. We're eager, we jump, we want to address and take care of everything. And that's how we kind of find ourselves creating that opportunistic environment of all these other tasks and asks being brought to us.
It's almost like, I've equated it to my residents as pharmacy and Tala, like you can't turn anything away, and so, by having that ability and I think you've made a good point, Jimmy, in the paper, and maybe a perspective from all the rest of the authors as well. We're not saying we wanna take away, like, helping with boarding patients altogether. It's more so if you can just offload a few things, it'll absolutely help the EM pharmacist, it'll help the patients, it'll help overall standards of care, throughput, all of those things. And you don't even necessarily need another FTE generated. It's more so just being creative with the FTEs that you have available without just isolating your EM pharmacist and running them ragged. There's one aspect that we brought up within the paper that got a little testy with some reviewers was the sense of having patient ratios. Now, patient ratios have been documented pretty well within the ICU literature. I know Mitch Buckley had put out a nice paper from the ACCP, Crit Care PRN, essentially about this. But there's none of that for EM pharmacists. Nobody has like whatever the magic number is, and a lot of that is because, the acuity level and the responsibilities are gonna change from institution to institution. But ultimately, there is a safe or uh, what most efficient, value for that. It's not quantified yet, but there's gotta be. There's absolutely it's not a reasonable expectation for, Alyssa to walk into 50 boarders and then also have to take care of, 20 new EMSs that roll up, with 3 of them being, critically ill and needing, time-sensitive interventions. It's just it's more of an equity process as much as anything.
And I think when we chat about this, it appears that it's just about us. And what I want to transition to, and Heather, you can kind of take the lead on this, is what can go wrong when the boarded patient have no clear pharmacy ownership?
Yeah, I think yeah, that's a key point and something that we kept talking about through the paper is how this would be perceived. And we know these patients still benefit from a pharmacist involvement. Um, but it's that handoff piece. And when there's no clear ownership of a patient, and this is true regardless, although again, since staffing is usually location based, it's a little easier to identify ownership by medical unit. But when they don't, that's when those transitions of care, the follow up is lost. If you have a technician or an intern doing a med history and there's something there that could very well be why the patient is there or a reason that they need to be. And then it's just handed off to someone else. Again, the time piece of not being able to schedule the task, have timely follow up potentially if the EMP is busy with a more critical patient. Um, that's when errors happen. That's when we just can't optimize the patient's care. For a pharmacist to take and have clear ownership of that patient with clear handoffs as they move forward through their trajectory of care, that is so much safer for the patient. And again, it will optimize their care and provide better outcomes. When it's choppy and we're not sure who's following that consult, or have you followed up, or you know, who gets that message back from the hospitalist about the question you had, that maybe EMP doesn't even usually work in that realm. Those are all kind of dangerous areas for our patients.
And you mentioned this, there's a lot of components to this. So we mentioned, okay, if the ownership of the boarded patient isn't there, wasn't taken care of, but then we think about, okay, we heard leadership, we're gonna go take care of that boarded patient. We're gonna spend that time on them. Now, what can go wrong when the EMP again is pulled away from the emergency workflows? Can you kind of dive into that? You guys can chime in as well.
Yeah, it's right, like, that's the we are the area, there's not a lot, that's specialty. If we are looking at emergency medicine as a specialty, responding to those critical patients, resuscitations, stroke codes, trauma codes, uh, there are not pharmacists, usually that can backfill for us, and so, our, uh, internal medicine pharmacists, they can help more with the boarded patients and letting us stick to our specialty. That's when I think things are missed. As everybody's talked about, it's that diagnostic piece. It's that, oh, no one happened to see that that stroke patient is actually on a thinner, even though it wasn't on their med list. I, you know, we know to look outside that med list. What's on their fill history? Dig that a little bit deeper than, our team can do a great job, but pharmacists provide that extra level. And if that's missing, again, that's a risk for errors. Then our critical patients aren't having that optimization, and given their acuity, that can be more dangerous, especially time wise, than some of our more stable, boarded patients.
And one of the things I want to capture, and I think of this because I've sat in some of these meetings to which harm is more visible to leadership? And you guys can chime in. Is it the miss border medication or absent pharmacists doing resuscitation? And I'm pretty sure our physician leadership would say one thing compared to some of our other leadership that we respond to.
Yeah, that's so tricky. The ER is gonna say, "Where were you?" Well, we needed you on this case." Um, and that may or may not get up to, administration, looking at missing meds and number of, secure messages that go to pharmacy, and, raise awareness with our technicians and central pharmacy. Um, they don't maybe have that same value. So I don't it's a really hard question of what is causes more harm, and what leadership see, because they're so different.
I think that part of the reasons it's so difficult to answer is that there is not a great strategy from
Right.
leadership in terms of who owns patients. What is the process? It's one of the things that Alyssa mentioned is that we love the chaos, but structured chaos in the sense that you want to be able to know when you walk in what are your roles and delineated responsibilities. And unfortunately, with boarding patients, as it relates to pharmacy, we're not able to really truly identify ownership, and that's really probably the central key aspect. And one of the things that we tried to highlight within the paper is that ownership of patients and where they essentially are going to be managed. So I think that's part of the reason we're having a little mic shyness because it's so difficult to try to figure out based upon again that delineation that's just not clear.
It's tough, guys, and we've talked a lot today about ownership, and Alyssa, I'm gonna kinda have you help me with this part here, and let's just say we're gonna build a workflow live, and I would love to I love doing these, and what I'll do is I'll just name a task, and you can tell me who should usually own it based off this. If you had a magic wand and, you got the top of the food chain and said, "Hey, Alyssa, we can give you whatever you want with your workflow, and let me know. We're all ears." So the first thing I wanna start off with is gonna be, again, all you guys can chime in, but, high risk ED medication decisions. Who should be taking care who should own that?
EM pharmacy,
All right, next, again,
hands down.
routine verification of non-urgent inpatient meds.
Pharmacy staff,
Perfect. Medication histories.
pharmacy staff,
All right, missing medication follow-up.
pharmacy staff,
All right, automated dispense cabinet optimization.
EM pharmacists,
Okay, okay. Discharge medication planning.
inpatient pharmacy,
All right, antimicrobial, anticoagulation monitoring for admitted boarders.
our ID team for sure,
Escalation of unstable boarders.
EM pharmacy,
All right, lastly, in education and simulation.
EM pharmacy.
See, this would be so great. We just sat down with a piece of paper and everyone just sat back and just like clicked it up. All right, this is what we're gonna do. This is the workflow, and that's why we need everyone here and all of you guys that's participating and that's going into leadership to be that EMP that's sitting at the table making those workflows. But my follow up for that again, what again is there anything I mentioned? What tasks should EMPs touch only when they're high risk, urgent, or ED specific? If I missed anything.
I think that's where the ADC comes into play here. I think you kind of paused when I said EM pharmacist, but we have such an opportunity to know what is needed, how it's needed, and the utilization in EM practice that it's easy to try and standardize processes across the entire hospital. But EM is so different. And I think that one of those is our inventory, how things are used, even down to how medications are prepared, can help us to really optimize on what things are done. Because being realistic, I think we're the pharmacists who have the most hands on involvement with medication preparation, how it's being administered, what questions, and the way nursing is handling these. So I think it's a big role for us in that piece.
I would just add to that, Alyssa, though, I think it does depend on what we're optimizing. At my shop, when we started to have a lot of boarders, it was maybe we should start putting some of the more routine meds into our ADC cabinets. And again, that was an area where I'm like, I think we should consult an inpatient pharmacist that knows our protocols and our formulary switches. I can definitely handle a lot of the ER pieces. And just like you mentioned, what is our inventory and what should be on override and what should not? But again, if we're looking to optimize some of those routine meds for our boarded patients, that's a good opportunity for our inpatient pharmacy staff to help us with that.
Another aspect of is just getting our IT team to help us because sometimes it's maybe it's just a report. And another caveat that I've thought about when you guys were talking about this is it really also depends which nursing staff is handling those patients as well. Because we have a ops unit and kind of a boarding unit where sometimes it's staffed by our ER team, and those nurses are gonna come to me regardless because they so I need to know what's gonna be in them versus if I have some people coming down from medicine that's hanging out, they're gonna be used to their own processes. So I think depending on your shop and depending on the composition of your team, and sometimes we'll have PAs in the mid-levels managing some of those patients through the boarding process. So for me, even if it's something as small as what's in those omnis, I got asked the other day to help optimize eye drops for our diagnostic room. So it just really depends, I would say, on your shop, what your who's gonna be handling those patients because you're gonna get the question whether or not you can't tell them to go talk to the inpatient pharmacist. They're gonna tell you no. You answer the question. All right. We're gonna transition a little bit here and really get into this different models that could actually work. And Brian, let's you guys can kind of tag team this one here. Is there what models have you seen work? Is there anything out there when you guys got together as a big writing group? Was there any models that you guys saw that worked well?
Yeah, so there's just not a ton of literature within the pharmacy space for boarding in terms of development of that, but I think we mentioned a few that are worth exploring. I think that one of the things is if you can reshuffle or even generate FTEs for boarding, That's fantastic. I think that's probably like ultimate the like pie in the sky. I'm not sure how realistic that is, given that the boarding fluctuations and surges within hospital capacity make that extremely difficult. But I think that's where you can be creative as a pharmacy leader in developing surge plans. If we're on and stratify it, and based upon X number of borders, we're going to dedicate a half FTE to this. So we'll split a unit with somebody else that potentially may normally have so many inpatient inpatient numbers, and now you're going to take a little bit of this, and so you can actually divvy up a lot of this. This isn't again about passing off work to others. It's more about putting those patients into the specialist hands for neurocritical care or med surge trauma, those type of things. Having a dedicated transitions of care pharmacist also seems like a reasonable opportunity for them to be able to work within that ED on those boarding patients. I think that's a reasonable expectation or a reasonable um, stopgap to try to help with some of those. And again, even if they're not taking the full number of boarders, if it alleviates some of the burden that the EM pharmacist is having to do, I think that goes a long way in terms of uh, leadership demonstrating its support of EM pharmacy, and without getting into burnout, potentially reducing that level of given that you're essentially working as a 1.5 or even 2.0 FTE by being the EM pharmacist and now inpatient pharmacist at the same time. So that you just have to get creative depending upon your site. We tried not to get too specific and to say this is how you should do it because it's going to be very dependent upon your institution and your workload and the type of patient population that you see. But it's really up to your leadership in conjunction with inpatient as well as the EM pharmacist as well. I think that's probably the bigger thing that has to happen next with a lot of institutions is just having those discussions to try to generate those ideas and generate those plans, and then ultimately we have to study that and see if outcomes are better. I think that just being stagnant and, sort of apathetic towards it and just saying, "Oh, well, boarding is not going away. It is what it is. You gotta deal with it," is probably the wrong approach from, any leadership. But ultimately, that's gotta be the discussions that are had. I mean, boarding's not going away, right? So boarding, there's plenty of data to support that boarding versus admitting someone from an outside hospital is not as profitable. Like, it is what it is. Hospitals are going to take admissions from outside places. They're gonna continue to have those elective surgeries. Like, that's just not gonna go away because that's where money is made. I mean, that's definitive. There's literature on that. So, really, we have to have those discussions with our leadership, and we have to study it, and we have to have folks out there, willing to publish data on it.
And I think just within pharmacy itself, the ED is seen as that place, that location, and where these patients are physically housed when they're in the hospital. And even my own experience in my pharmacy team, we have internal medicine rounding services, family medicine. When their patients are boarding, those specialists are hesitant to step on toes almost because you're the pharmacist caring for that area. But I strongly encourage them, no, like this is your opportunity. This is how you can help us and with those other recommendations. So I think having that full team understanding of what boarding truly is, it's more than just sending medications to a different location, what we're used to doing. It's more than just adding hallway beds and finding unique ways to see more patients, but having a whole understanding from pharmacy to really support practice and having complete plans. They're going to adjust, they're going to change often, but really having that team based focus of what the EM pharmacist role truly is, what specialty we bring to the table, and how we're helping with patient care, and how the rest of our team can support what we need for our patients in that location.
This is unique, and I think the models work great. And Dave, I want to kind of transition to you when it comes to like how to talk about this politically. Again, everyone here can chat about that, and it's just it takes a different way of talking to different people. So I guess the first question: how can EMPs really explain this without sounding like they're not refusing patient care? Because that becomes an issue.
Yeah, no, absolutely, and this is definitely one of the, hot button, topics of it, and we had a lot of discussion on it, but I think you just have to frame it for what it is, right? It's patient care and safety when it comes down to it. Why is the ED the only unit? Let's say you have 30 beds in your ED, but you have 60 patients, right? Not including waiting room or anything like that. Why is it acceptable that only in the ED to have hallway patients or other unique areas in your ED that you can start seeing patients? I know when boarding got really bad for us, our EM leadership had a discussion with inpatient teams and basically said, well, why can't we just send a patient up in the hallway on an inpatient unit, right? What's the difference than what they're doing in the ED? Staffing ratios are staffing ratios. So why do we get a blank stare? Like, that's crazy. You can't treat patients in the hallway. We're like, we do this all the time. I have critical care patients in my hallway right now. Um, so we basically need to frame it like that. Um, we can only do so much, right? And pharmacists, and I think you already mentioned EM pharmacists, we want to try to save everyone, help everyone. But you can only take care of so many patients. And once it becomes too much, that's when errors are going to occur. And it's not that pharmacist's fault. It's not inpatient pharmacist's fault. It's the system fault. And we need to kind of come up with solutions to prevent that.
And when we're chatting on people, I think you kinda touched on it a little bit, how your physician group and did that, but what language have you noticed work well with physicians and nurses? Because sometimes there's, like, some key words that seem to just click for some people.
Absolutely. Once you kinda say these buzzwords, everybody kinda just stops and listens, right? Just like in a resuscitation type of thing, and, again, credit to our EM physicians, organization-wise, our EM nurses as well for bringing attention, advocacy to the issue, but, first thing is cost and avoidable costs. Obviously, finance is a huge issue amongst all of the institutions. Burnout, staff leaving, patient and family stress, right? Patient satisfaction scores, and then you look at other metrics that ED is typically, forced to evaluate, like ED wait times, left without being seen. So if you bring up these metrics, I think that can really go a long way and help, bringing attention to the issue.
Has anyone had any language that works well with pharmacy leadership? I've had a great opportunity to work on my team, but have you guys noticed anything that worked well for you? Because again, some of it's working in some places.
Yeah, I haven't as I can't think of an exact, like, term, but what I try to do is kind of explain it just because, pharmacy leadership, no, disrespect, they take care of the whole hospital. They might not have a great idea of ED workflow and the ED process down there, but basically, I think an easy way to kinda explain it is, let's say you have another, inpatient pharmacist, whether, it's a medicine service, ICU pharmacist, they have a 30-bed ICU, and now a new 30-bed ICU is opening up, and you tell that ICU pharmacist, hey, you have to cover both units and you have to round somehow at the same time on both teams, right? Do you not think that that pharmacist is going to push back against it? Right, it's the same thing here. So, kind of equating it to the best term for that, but that type of situation to show that we have a finite amount of resources and abilities, and once that gets stretched too thin, that's when errors can occur.
That's great. I think just really figuring out what matters to your team. And what I always like to do is figure out what's happening in the C suite as far as what metrics they're tracking and what are their pillars for this period of time, and figure out how can I some way, like for us, I did a street medicine program, which is completely kind of off tier, but we have a health access pillar that they're focused on in the C suite. And I just tied that very nicely to that to figure out how can I get that taken care of? How can I also prevent representations? How can this improve ED throughput time? And it's like, oh, this is great. Let's celebrate this. Because again, figuring out what matters well to them. Another aspect that I really want to kind of capture is that, again, boarding patients deserve pharmacy care. Again, that's the one thing everyone's really saying. They deserve the care. They also deserve clear pharmacy ownership, to be honest. And the EMP should not be the unspoken default. If your ED set up, we have an FTE for EMP to focus solely on that for a shift. Then okay, well that's interesting. But hey, that can be a case if you have an internal medicine or transition care. Brian kind of mentioned a few different models that could work, but the goal is, and what I've captured from this, and the thing that we looked at from an organizational perspective, is that term default for these patients, and that's one area that I want to kind of dive into and make sure that everyone's getting from this aspect, is making sure we have a clear focus on and having a conversation around these things. But I wanted to kind of wrap up here, and BG, we can go back to you and really kind of finish up on a couple of these things. Because again, we've kind of answered some of them, but I always want to dive deep and repeat. What should pharmacy leaders measure when it comes to this?
Yeah, I mean, it's really institution specific, but I think that there are efficiency processes you can look at. Obviously, I think hospital wide, you can get kind of fired up of whatever it is the C suites have fired up about at that point, and make that an effort within the boarding process. So, is it throughput? Is it length of stay? What are the different aspects with as a pharmacy leader that I could potentially look at? So would it be the patients that are boarding more than X amount of time end up having X percentage longer stay than and whatnot? And then really it's trying to do some RCAs and evaluating whether or not, a lack of dedicated or specialist pharmacists in that particular case? Is it because that there were small little nuances that got missed because the EM pharmacist is not trained for that? So I really think it's just catering and individualizing what it is that is most important at that time for um, your pharmacy leadership, the C-suite leadership, and then identifying what potential stop gaps there are. But like you said, I mean, just because of a location, they're there does not necessarily mean I'm the most qualified at that point. There we were very cognizant of the language within the paper. I think we had about 4 or 5 different versions that were maybe more course than other versions. And this is not about saying we're trying to get rid of work. It was certainly not that. It's more so just trying to put the pharmacist that's going to be able to provide the best care for that patient at that time. Like, I feel like that's a patient right. Should I be caring for a transplant patient and managing autoimmune and or autoimmune immunosuppressants? No, I probably shouldn't. Um, but at the same time, I also am not going to just steer away from it. I'll do my earnest best. But those are different stopgaps that you can evaluate depending on your patient population to look at those little nuanced things to again impact patient care. But ultimately too, the problem is, as you said, we've all got, 20 to 30, 50 plus borders is now you're taking away time from innovation from the EM pharmacists, protocol development, um, research, all of those things are now getting put on the back burner and now you're not able to innovate like you would potentially. But I think one of the things as an EM pharmacist you can still continue to do is look at processes that make your ED more efficient, that makes the inpatient stay more efficient. Whatever those things are, and that are holding up your processes and making them less efficient as a way of trying to measure and evaluate the potential need for more help. I think that people at least the environment or pharmacists in general, just they don't want to identify that they're potentially a flaw or an issue. They want to just try to handle it and sort of swallow it and go from there. But at the same time, like that's not what's best for patients. It's not what's best for the institutions. Um, and honestly, it goes into safety and potential financial implications, right? If I like make an error on inpatient boarding patient, like ultimately that's my license at risk, that's my family's livelihood potentially at risk. So, ultimately, it's about advocating for yourself and not just saying, "Oh, well, they're here, and that is what it is." It's sometimes it's about being the squeaky wheel and getting a little bit of the oil.
So I guess one of the things I want to do as we kind of wrap this up is kind of ask you guys and just get your opinion of if a director of pharmacy or ED medical director was to read this paper, what's the first operational change you would want them to make? And Heather, we can go with you first.
Yeah, I think the first thing that they should do is open a dialogue with their EMPs and really get to understand what the practice is, what roles are they doing. Hopefully, that will open up to some of just the dialogue about, how much are they pulled into boarding opportunities or tasks, and really start that discussion of where is the needs, and knowing that they change. I think that's the other piece that makes this really difficult is sometimes there will be lots of borders and all these tasks are not manageable. Other days, there are very few. And so maybe that FT doesn't make sense. Maybe that EMP can cover. And so just trying to make sure that they're starting that dialogue and being able to talk with the EMPs and really understand what current practice is and where they think they can really expand the practice and optimize by using some of these dividing of specialty areas.
Alyssa, go ahead, Brian.
I was just going to say this is a great chance to leverage technology and evaluating and having surge plans in place, right? So, like if there's 5 borders, I don't think that that's unreasonable for an EM pharmacist to probably potentially manage, but and depends on your institution. But like it just there needs to be a risk stratification, which goes back to sort of the issue that we potentially have in developing appropriate models is because of we don't have solidified patient ratios like other specialties. But having those surge plans in place, utilizing technology to maybe potentially identify patients that have complex medication regimens where pharmacists would be ideal. The patient that came in with an ortho injury that's just going to get surgery tomorrow and then be out the next day. Do you really need to have a dedicated pharmacist at that time? Potentially not. It just depends. But are there ways within your EMR or is there ways within your pharmacy surveillance programs to identify those high risk patients that really need a specialist care? You know, it could be potentially like, hey, I've got a neuro patient that now potentially is going to get flexed to the inpatient neuropharmacist that could evaluate that patient or trauma, whatever it is, it's not about adding, you know, 20 extra patients to someone else. It's about maybe divvying out that work a little bit more equitably.
Alyssa.
Yeah, so I think with that dialogue also showing, there's so much value in seeing what that relationship is and what we're really doing, how we're really intricated in patient care with nursing. I think we forget about that advocacy that nursing has for EM pharmacy practice. If we're not there, we hear about it. We hear from providers, there's opportunities to engage. So for pharmacy leadership, yes, they know we are appreciated. There's respect. But I think being in our shoes for a little while, understanding how we really contribute and the value we bring to patient care in those situations is critical in that support and recognition of protecting the role of the EMP. And from there, there are slower times, but there's also so many other things that we're doing with optimization, process improvement that we really contribute back more. And keeping that protected for us, letting us have that focus time to be able to improve processes beyond just maybe doing that med rec or looking for a medication because you're not busy in that moment.
David.
I think my colleagues all said some great statements. Good, um, yeah, no, good statements. I'm gonna be a little selfish on this one and just say operational changes, border orders can be done by non EMP personnel, whether it's central pharmacy, another person, but they can be delegated out. I'm gonna be a little selfish on that one.
Absolutely. And I think for me, it's just looking at taking that dialogue and seeing what does it actually mean. It will mean the world for me if some leadership came down to the ED and that during that exact time they wanted us to be doing these multiple things to sit beside us while these questions are coming in. To sit beside us while we're trying to manage being an RPD, sit beside us while we're trying to do all of that with smells, noises, all the components of the ER trying to happen. You're sitting in your ED trying to make these major decisions and just thinking about what will be the best utilization of our time. And I think that will be very helpful. Again, not necessarily something I know is going to always happen, but I think it'll be useful to at least start having a conversation or just having the thought of what am I actually asking this person to do that I'm not asking anyone else in the enterprise to do. And I think that will be a huge component.
And in addition to that, in terms of pharmacy leadership buy-in, one of the things that I appreciate about this paper was that it is advocacy effort from the from the PRN, and we were so grateful for SEMP and AMP to endorse it. But we really need our national organizations, our big organizations, to take a stance on this as well to protect. And that's going to be uh, gonna be necessary for them to collate a lot of different groups together. So leadership, EMPs, crit care, internal medicine, special, all of those different specialties need to come together to create, a consensus guideline, whatever you want to call it, that the EMPs and the inpatient and whoever, to be able to really um, create strategies for that. So I think one of the things that uh, for this podcast, if anyone's listening from the big organizations, that's something that we could really we're calling for help from, is to be able to get more organizations to discuss this and more organizations to create those strategic opportunities that we essentially call for within the paper.
It's been a great conversation, guys, and boarding is not going away tomorrow. The ownership is flexible, but the goal is really not less pharmacy care of these border patients, but the goal is the right pharmacy care owned by the right team. That's going to be without losing the EMP's highest impact value. I think we all want to be at the bedside. Countless times when a nurse will say, "Hey, if I come in, make sure you're there." And I think that's the where there is in the recess room, right beside our docs, right beside our nursing staff, really, using our brain to really take things to the next level. So I just want to thank everyone for coming on. Again, I know everyone's very busy. Three organizations put together. It's a lot of power here. And again, a lot of you guys have been people who I followed for many, many years. I'm super excited to get this out there. Well, guys, I thank you again. And I close this episode out the same way I've closed out all 130 before. You guys work in the ED, you guys be the pharmacist, but everything you do, make sure you farm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.